to wait for others to join us.
Okay.
Well, I can see that we have about 14 participants. I think it is time we set the ball rolling. So good evening once again.
Good evening, we are with you. Kindly go on.
Okay, we'll begin with an opening prayer, and I will implore that we pray in the silence of our hearts according to our faith. May God answer our individual prayers.
Amen.
Hello.
Yes, hearing you.
Hello.
Kindly go
Okay.
ahead.
Hey.
So I want to, like I said earlier, my name is Pharmacist Saleh Uba Jankaro. I'm a Deputy Superintendent of Police. I work at the police hospital in Uyo, Akwa Ibom State. And I have been nominated to moderate this training session. I welcome everybody on board, and I want to welcome and recognize our group coordinators under the able leadership of Pharmacist Folashade Olawal, FPSN. I also want to recognize our fellows, the fellows of PSN and fellows of West African Postgraduate College of Pharmacists. I also welcome on board our professors, our lecturers, heads of departments in various hospitals, our directors of pharmaceutical services in various states, our senior colleagues, VIPs, and other distinguished participants. I welcome you all on board. Today's training session is going to be taken by our distinguished speaker in the person of pharmacist Kingsley Ikunife. He is going to take us on the topic quality improvement and the medication use system. This talk will last for about 45 minutes. But before he starts, I will want to introduce our distinguished speaker. His name is Pharmacist Kingsley Ikunife. He was born on the 29th of May, 1971. He had his post-elementary education at Federal Government College, Ugolao, Ida, in Kogi State from 1982 to 1988, before proceeding to University of Nigeria, Nsukka, where he bagged a Bachelor of Science in Pharmacy in 1995. His working experience cut across various phases of life. He was an intern at the National Orthopedic Hospital, Igbobi, Lagos. He served as a core member at State Hospital, Ede, Osun State, between 1997 to 1998. He worked as a part-time pharmacist at Bernardo's Pharmacy in 1998. Pharmacist Kingsley Ikunife was employed in 1999 as a pharmacist grade 1 in National Orthopedic Hospital, Igbobi, Lagos, and rose through the ranks to his current position of a Deputy Director of Pharmacy. As a career pharmacist, he was the former Social Secretary of PSN Lagos State between 2011 to 2013. He also served as Vice President, National Union of Health Professionals from 2011 to 2014, Igbobi Chapter, Lagos State. He is a member of other professional bodies locally and internationally. These include International Pharmaceutical Federation, FIP, with headquarters in Hague, Netherlands. He is equally a member of National Association of Hospital and Administrative Pharmacists and the National Union of Healthcare Professionals. He is a fellow of West African Postgraduate College of Pharmacists. He is a Merit Award winner, Lagos State PSN, and a Distinguished Service Award winner of AHAP, Lagos State Branch. Pharmacist Kingsley Ikunife is a devout Christian and a Catholic, an entrepreneur par excellence, and the CEO of Kingsland Pharmacy Limited, Satellite Town, Lagos. He is happily married with children. I now welcome Pharmacist Kingsley Ikunife to set the ball rolling for his presentation. Thank you very much.
Thank you, Pharmacist Uba. disabled participants. Okay, can you disable? I think my sharing screen, I can't share my screen yet. I'm being disabled by the host. Dr. Ibrahim Bello.
Kindly go ahead. You have been enabled. Kindly go ahead. Yes.
Okay.
You can share now. Yeah.
Yes, I think.
Good. Yeah.
I hope you can see my screen. Okay. Good evening,
You're
my
sharing
dear
this.
professional colleague. Okay. I hope you can see my screen now.
Yes.
Can I? Okay, thank you very much. Good evening, all my distinguished professional colleagues. I welcome you all to today's training section. Yeah, I'm going to speak into the topic quality improvement in pharmaceutical care and clinical pharmacy activities. Okay, this is my outline. I'm going to do a few definitions, and I'll talk about the several methodologies available for quality improvement. I'll also go ahead and talk about how do we measure quality of care. And I'll also talk about performance indicators that can actually help us monitor quality improvement. I'll also talk about benchmarking before I now conclude. Now, by definition, quality healthcare is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So the key points to note here is that quality healthcare must be associated, must be consistent with current professional knowledge. That shows that pharmacy is very dynamic. We have to continue updating our knowledge. If it is not consistent with the current professional knowledge, then there's no quality in that healthcare. Now, I'll also talk about what quality improvement is. Quality improvement is a systematic data-guided activities designed to bring about immediate improvement in healthcare delivery in particular setting. What is just talking about, the keyword here is it must be systematic, and it must also be guided by data. Again, I want to talk about quality improvement strategy. This is just any intervention aimed at reducing the quality gap for a group of patient representatives encountered in routine practice can be referred to as quality improvement strategy. Now, we healthcare professionals be confused at times with terms like quality improvement, quality assurance, quality control. Quality assurance, quality control, and quality, they are totally different from each other. What we are talking about this evening is quality improvement. And there are several attributes of a quality improvement. These are the several attributes that an activity must have before you can consider it to be a quality improvement activity. One, it has to be prospective. So it should be something continuous. And then a team must be involved in making it happen in the hospital or in an institution. It must be non-punitive. And it has to also be system-oriented. It's not something that depends on an individual. It has to be system-oriented. And it is also customer-focused, or I like to say patient-focused. Then it must also be data-driven. Now, I'll just quickly start talking about the methodologies available. Okay, for quality improvement. There are several of them, but the most common methodology is one known as the Darwin cycle or Shehart cycle. It's also referred to as the PDCA cycle. The PDCA is an acronym for Plan, Do, Check, and Act. This is just the steps involved in quality improvement methodology. The first step is that you must plan. This planning involves designing a new approach. We have to follow guidelines and procedures to be able to improve any quality in your system. So you design that approach. After designing an approach by setting out the guidelines or procedures, the next thing you do is to implement the designs. And in implementing designs, you must also collect data. Remember, we said that the attribute of a quality improvement, it must be data-driven. We pharmacists, we must collect data, and we are used to collecting data. This data is something that must be collected. It's part of quality improvement. If you're doing anything, you're not getting data from it, you can refer to it as quality improvement. So you must collect data in everything we're doing. After implementing and collecting data, we have to do an objective evaluation by assessing our results that we're getting from whatever we have implemented. That's actually called check or studying it. Okay. And after that, the next thing we do is to action taken on the results we have gotten. Performance data we've gotten must be acted upon to standardize the new plan. If there's an improvement, after planning, you're doing it, you're checking it, you're acting on it, and there's an improvement on any quality improvement activity you are designed to work on. If there's an improvement, then you repeat the PDCA cycle. It's a cycle. You continue improving on what you have done before. Now, this is the first methodology. The second methodology I want to talk about is called the focus PDCA methodology. This is an expanded PDCA methodology. In this case, first of all, the focus here stands for find, organize, clarify, understand, and select. Now, what this is saying that, first of all, before you can, it's an expanded PDCA. You must, first of all, find the progress targets for improvement, the process targets for improvement. I'm going to talk about that later. In any structure or in any quality category, you must also they're actually divided into three parts. We're talking about the processes here. We have the structure, we have the processes, we have the outcomes. We're going to find the process that is targeted for improvement. You must identify it. It could be an example, could be the pharmacokinetic service referral process. This is the activity you want to improve because you're having one or two problems with it. Then the next thing to do is to organize a team to study the problem. A team here includes medical healthcare teams, which includes pharmacists, physicians, nurses, etc. We organize a team that will work on it. And this team, there must be a clarification. Each member of the team must get a clarity on the understanding of the process. Every member of the team must understand the process. They must also go ahead to understand the root causes of variation in performance in the first place. So everybody is carried along in this matter. Then finally, we select the part of the structure or part of the process we want to change. Once we have selected the part of the structure we want to change, we now go to plan again, and then do the do, check, and act steps. So this focus comes first, after which we now go to the PDCA aspect again. Now we have another methodology, which is also called, there are several methodologies. This is also called the W. Edwards-Deming theory. This has to do with in fact, Deming is referred to as the father of total quality management. Here we talk about organizations involving management. We have teamwork and when defined processes which involve system thinking and constancy of purpose. In this particular theory, the entire organization must be committed to quality and improvement to achieve best results. We also have the clinical practice improvement developed by Horns and colleagues. This is another methodology. There are different types. In this case, you have a direct application to the clinical management of the patient, individual patients. It involves a team, determines a purpose. We also collect data, assesses the findings we collect, and translate findings into practice changes. These are all interrelated. I just give you, then I want to talk about finally about the 6 Sigma. These are all methodologies involved in quality improvement. The 6 Sigma involves a 5-phase process. They define, measure, analyze, improve, and control. It's a 5-phase process, and it's consistent and practical approach to reap profitable benefits. And it also involves a strong problem-solving team and data accuracy that helps find the root cause of the problem. These are all different methodologies. You can choose any one you want, but they're all interrelated. But for me, I recommend the Focus PDCA cycle. That is by the Deming methodology. That is the most popular and that is the most common. Now, this is summarizing the whole methodology. The Shojania et al. Summarizes the classification of quality improvement. And the summary of the whole thing we've been saying is that the choice of quality improvement strategy you choose and methodology is dependent upon the nature of the quality improvement projects. That's just the summary of what we're talking. So it depends on what you want to do. But like I said, based on experience and comprehensiveness, it's better for us to adopt the focused PDCA cycle. Now, I'll just go straight to the most challenging thing in quality improvement is how do you measure your quality? How do you measure quality of healthcare? In measuring quality of healthcare, we have just two goals. The first is determine the effect of healthcare on desired outcomes. This gives us an opportunity for improvement. Secondly, the second goal is to assess the degree healthcare adheres to process-based scientific evidence. And this helps us gauge the impact of changes on our policies and procedures. Now, the Canadian framework actually simplifies quality healthcare in order for it to be easier for us to measure. And it simplifies it to three. He said that healthcare should be divided into three care parts. The first is structure, second is processes, and third is outcomes. So if you want to measure the quality of your healthcare, you should be able to understand that each healthcare, in any healthcare institution, the structure, the processes, and outcome are what are involved in quality improvement. Now let's go straight to the structure. Structure talks about the staffing and all the equipment in the hospital, and then the guidelines. Whereas the processes involves the interactions and investigations, examination and treatments that patient gets. Of course, patient counseling as well. While the outcome talks about the mortality and morbidity ratios, patient satisfaction, and also goes further to talk about the economic, clinical, and humanistic outcomes. Now, I'll still talk about the structure because it's important we understand it. The structure talks about the characteristics of the providers. It has to do with the professional licensure, the licensing and certifications, computer systems, and all of that. And I must say here that the structure is necessary for optimal care, but does not ensure optimal care. What ensures optimal care is the processes. In this process domain, this is where every healthcare professional strives to give his or her best to the patients. The process involves the activities, all the activities between the patients and the providers. It has to do with our products, the services we render, and the practices, all the practices we make. I want to also state that this process can be divided into two domains, the technical domain and interpersonal domain. The technical has to do with all the gathering of patient information, entering prescription information into the system, reviewing patient records, checking prescription levels, evaluating laboratory results, and resolving potential drug-related problems. While the interpersonal is when you develop the interpersonal relationship between you and the patient, which has to do with empathy, listening attentively, and caring relationships. So this is the most important aspect in quality improvement, the process aspect. We also have to talk about the outcome. The outcome here has to do with the consequences of Medicare, which has to do with death, disability, disease, discomfort, and dissatisfaction. Like I said before, outcome also involves economic, clinical, and humanistic outcome. Outcome can be intermediate or long term. For example, if you have a patient that is using a diabetic patient, and you as a pharmacist is trying to educate this patient on how to use the glucometer. Using the glucometer will lead to a long-term improvement in patient quality of life. But that patient quality of life is the outcome. We have intermediate outcomes. For example, getting used to or using the glucometer properly will lead to the patient understanding how to use the glucometer. That is one intermediate outcome. It will also lead to patients can be adjusting therapy of insulin. That's also an intermediate outcome. Adjusting doses of insulin. Then finally, it can also lead to patients getting better quality of life. That is long term. So like I said, it's just a chain of events between the process and the outcome. So, but like I said, the process is better because monitoring. Now, let me just talk about performance indicators. Sorry. Now, in this cycle of quality improvement, performance indicators are those activities that help us monitor our quality improvement. I've talked about measuring quality improvement. I'm talking about monitoring quality improvement right now. We can also monitor our quality improvements by using performance indicators. Performance indicators actually help us to monitor and measure quality as part of check function of quality improvement. It focuses more on processes and outcomes at times. For example, then performance indicators. We have process indicators, we have outcome indicators. Process indicators are preferred because of the following reasons. Outcome indicators are sometimes difficult to measure. Like I said, outcome indicators are also very, very far from the process. For example, you have a 10-year survivor of cancer. Patient 10 years survivor of cancer. 10 years. Outcome, the 10 years is a long time. So we have so many processes in between. So, like I said, the processes are better performance indicators. Now, outcome is also influenced by many factors than the process. Okay. For example, the diabetic care program I talked about, assessing appropriateness of insulin dosage adjustment is more useful to us than the rate of hospitalization during a 5-year period. Like I was talking about, that is the appropriateness of insulin dosages are the processes or an intermediate outcomes, while the long-term outcome is the hospitalization that occurs during the 5-year period. Now, performance indicators are further divided into sentinel indicators and aggregate indicators. Sentinel indicators has to do with when a serious event occurs and needs further investigation. For example, adverse drug events or deaths. When we have a summary of frequencies of numerous cases, that is referred to as aggregate indicators. For example, number of turnaround time for maybe meeting a prescription within 15 minutes. This depends on the patient. Some prescription can be done within 15 minutes, some can take longer. So now, indicators can further be divided into continuous indicators and rate-based indicators. Continuous indicators can be by just simple count. Like I said, there are numerous cases. Just count them. The rate-based indicators, when you have a ratio, where you have the numerator and the denominator, you have a ratio of activities that conforms to the standard. For example, the proportion of start orders dispensed within 15 minutes. Now, this can be compared with all the prescriptions that come to the pharmacy. Now, you get the ones that were dispensed within 15 minutes and the one that compared to all the prescriptions that came to the pharmacy. Now, for a performance indicator to be ideal, must be clearly defined, must know what it means clearly, must be quantitative, means that it can be measured, must be very reliable in terms of, must also be clinically meaningful and actionable at any time. Now, these are sources of indicator data. These are where you can get your indicators, your process indicators. First, you can get from medical prescription, also get from administrative claims, you can get from operation records, you can get from patient reports. Now, they all have their shortcomings. For the medical prescription, it's very slow and labor intensive, but very rich in information. The administrative claims has to do with electronic formats, but limited usefulness because of lack of in-depth information. You can also get our indicator data from operation records, where they talk about the process of care. For example, designated time frame for medication orders. You can also get our indicator data from patient reports. Patient reports, this is talk about patient satisfaction from patient feedback. This is how we call hybrid approach. It's actually more reliable and broad-based. This has to do with having two sources of information for one care process. Now, after getting your indicator data, we must also, as pharmacists, learn how to interpret and make this our indicator data actionable by converting them into Pareto charts, bar charts, scatter diagram, regression analysis, run charts, and control charts. All this helps us to actually interpret this indicator data. For example, for the bar charts, you can now know that the one that has the highest bar, that is where you're supposed to concentrate. That's the one that has the highest where the problem exists at the highest percentage, or the bar chart or whatever you like. So the indicator data, we as pharmacists must also learn how to convert them into interpretable and action information. Now, there's some processes when you want to construct process indicators. The first step there is to identify an area of concern. And I'll give you an example. Now, if an area of concern in your institution is that patient understanding of a medication regimen is poor, so you have identified this area. What you want to do next is to select the process to study. Like I said, process. We have structure, we have process, we have outcome. What is the process that affects this patient understanding of the medication regimen? The process that directly affects patient understanding of a medication regimen is the dispensing process, specifically the patient counseling. So we select that process. The next, we determine what can be measured to evaluate the process. Now, what can we measure to evaluate the process of dispensing or patient counseling? The first thing we can measure is to measure the frequency of patient counseling. How many times do we counsel these patients? Then we can also measure the accuracy of information provided to these patients. Then the next step, after determining what to measure, is to define the numerator for your indicator. Like I said, all our indicators, rate-based indicators, must have the numerator and must also have the denominator. Now, the numerator is what, for example, in this particular case, the number of patients cancelled within a specific time interval, for example, 1 month. That should form our numerator for this indicator. Then for our denominator, we define our denominator as well. It can be referred to as the number of prescriptions dispensed in a time period. Okay, this is the denominator. The numerator should be the number of patients cancelled, while the number of prescriptions dispensed is the denominator. Then, after that, the sixth step is to determine the method for data collection. It could be by automated reports of visitors, and it could also be by record by pharmacists on his notepad or his electronic record. Then the last thing we do is to select tool to display the indicator data. I just give an example, run charts. Run chart displays results to provide quality assessment using your internal and external benchmarking. This is where benchmarking comes in. Whatever we got in after our data collection, we must represent it in a format such that we can all understand it. And then we use bar charts, or we use run charts, or we use pie charts. It becomes interpretable. Now, there are several key performance indicators I try to extract. That can help us. We can work on it as processes in our various institutions to improve quality. These are key performance indicators that represent clinical pharmacy activities demonstrated to improve patient outcomes. If we can do all these things, and then there are all ways of quality improvement, and they're all. Number one, the first one is the proportion of patients who receive formal documented discharge medication reconciliation, and the resolution of identified discrepancies by a pharmacist, technically called discharge medication reconciliation. How many of our patients get discharge medication reconciliation? When they discharge a patient, like in my institution, we are always there for the patients. We go and see these patients in the ward and then try to reconcile all their prescriptions. Most of the time when they're going home, they go home with a lot of drugs from different consultants. As a pharmacist, we're there to reconcile these medications for them so they don't take drugs that they're not meant to take. Then another one we can do is to the number of or proportion of patients who receive formal documented medication by a pharmacist. That's what we do with admission medication reconciliation and best possible medication pharmacy history. This has to happen. You will agree with me that so many patients come to the hospital. They come with different drugs. Some have comorbidities. Some see different doctors. So at the point of admission, as a pharmacist, we have to reconcile their medication. This will go a long way. This is one of the key performance indicators that has to do with quality improvement in the hospitals. Now, the third one I have here is the interprofessional patient care rounds. This is in my house we call it the consultant ward rounds. This is where all the healthcare professionals go on rounds. In this rounds, you have to check what number of professional pharmacists who actively participate in these ward rounds to improve patient medication. Must be able to get that data and work on it. If it's not working, then we must do something to improve on it. These are the things that keep performance indicators actually improve our quality as far as hospital pharmacy practice or any community pharmacy practice, any pharmacy practice whatsoever is concerned. Now, we can also talk about the number of professional patients for whom clinical pharmacists have completed a pharmaceutical care plan. Our practice is patient-oriented. We are patient-based oriented for those that work in the hospital. I must learn how to formulate pharmaceutical care plans for all our patients. This is a critical activity area. Now, if you're not formulating care plans, then you're not fully involved in patient management. Every pharmacist must know how to formulate a pharmaceutical care plan, how to set your goals, how to achieve your goals, how to monitor your goals, how to measure your quality. Then we must also know the fifth one I have here is the number of total drugs therapeutic problems resolved by the pharmacist. Each time you go to the ward and resolve any therapeutic drug problem, it must be documented. Like we say, if you don't document it, you have not done it. So we must be able to write it down, number of drug-related problems that we're able to resolve by pharmacists specifically. This is a part of our pharmaceutical care. Now, the sixth key performance indicator here is number of operational pharmacists that comprehends direct patient care by the pharmacist in collaboration with the healthcare team. This has to do with pharmacists going on the ward round on their own, being proactive, going before the consultant ward rounds. This is pharmacist round alone, not interprofessional. Pharmacists should be able to go to the wards on their own and clock these patients, and then be able to understand and solve the patient therapeutic drug problem as much as possible. Pharmacist must learn to be at the best sides of this patient at all times. Then we also have the number of professional hospital pharmacists who receive in-person education from a pharmacist about their disease or medication during the hospital stay. We call this patient education. How many patients did we give patient education? Talking to them about their diseases, talking to them about their medications. We note it down and then document it. These are key performance indicators that improve our practice. Then let me just talk briefly about benchmarking. Benchmarking is a process. Can be defined in healthcare as a continual and collaborative discipline of measuring and comparing the results of key work processes with those of the best performers in evaluating organization process. Benchmarking is just simply about comparing. You must compare what you do with what others do. You must compare what you do inside your hospital amongst yourself from time to time. Benchmarking could be internal. It could also be external. In internal benchmarking, you compare your services and practices to yourself over time to see whether you're improving or not. We also have external benchmarking, where you compare your institution to other similar institutions in size and then compare the pharmacy services offered. Benchmarking should not be a one-time event, but rather a continuous process, because the best practices of today often become the minimum standards of tomorrow. As we pharmacists, we are lifelong learners. One of these 8-star pharmacists is that we must be a lifelong learner. We must continue to improve. We pharmacists must continue to improve. So benchmarking is not a one-time process. It's a continuous process. But what we do today will definitely change tomorrow. Why do we even benchmark? We benchmark because we must measure. Like I said, it's comparing. Measure ourselves against industrial leaders. What this means is just measuring yourself against the best, which has to do with our products, services, and practice. And it's a systematic identification and implementation of best practices. Benchmarking helps us to implement best practices. Now, in conclusion, I like to say that the healthcare system continues to evolve towards value-driven healthcare. As pharmacists, we should understand how to measure, monitor, and improve quality, and be ready to quickly adjust to the challenges in quality improvement. These are my references. Many thanks for listening.
Thank you very much, sir.
Thank you.
Thank you very much, pharmacist Kingsley Kunife. I am so impressed by you were concise and straight to the point, and you kept within the time frame.
Yes.
So thank you very much.
Thank you, pharmacist. Thank you.
So this is now the session for questions and answers from our participants. Please, if you have any question, you indicate by putting up your hand. Hello, distinguished colleagues. I said this is time for questions and answers.
Maybe the speaker can stop sharing his slides so you can see people. Yeah.
Okay.
Stop sharing your slides so you can.
Okay.
Just click on stop share. Yeah.
I want to stop share. Because you say stop share on top of share. I click share. Okay.
Okay. Okay, we can continue.
Yes, I can see. Yes, I can see two people with their hands up. Pharmacist Kayode Okunlola. Please, you may ask your question. Pharmacist Kayode, you have the floor, please.
So you can unmute yourself. You're free to unmute yourself.
Okay. All right, sir. Am I? Hello, sir.
Yes, we're hearing you. Can you go ahead? Yes.
Yeah, thank you for giving me this opportunity. I joined at not I didn't start with you, but I was just wondering that for me, why should I need to have this knowledge? I didn't know. Maybe it was the reason was given. That is, what's the reason for me to have this knowledge of quality improvements in pharmaceutical care? Thank you.
Thank you very much. So, Pharmacist Kingsley.
Okay. Can you hear me?
Yes, I can.
Okay. Thank you very much for your question. We're talking about how we as pharmacists, this quality improvement has to do with the several methodologies for quality improvements. And you know, when you say quality, it's so difficult to measure quality. But this presentation tries to bring out, how do we even measure the quality of care? How do we measure quality of care? So I try to tell us how we measure quality of care, how we monitor our quality of care. Now, in measuring quality of care, you have to know that every institution is divided into 3 parts, which has to do with the structure, the processes, and the outcomes. Now, I was talking about concentrating on the processes, that the structure does not really improve our quality. What improves our quality is how we strive to improve the processes. And there are several processes. I gave several examples in my presentation. For example, if you're not dispensing, if there's a delay in the dispensing, maybe you're supposed to dispense every prescription within 15 minutes, and there's a delay. or maybe patients do not.
Kindly mute yourself, Pharmacist Kingsley. You are muted here.
Maybe there's about 30% of 30% of your patients are understanding the counseling of pharmacists. You need to investigate and find out why is it just 30% that are understanding. Maybe the pharmacist there is not counseling properly. Then you have to improve. So when you compare that with all the patients you're getting, this quality improvement just tells us about how do we improve our quality in the hospitals. That we must be able to take down, not just we're not just working, we're able to document what we are doing. If patients are coming to our hospital, we must be able to document how many of them, for example, know how to use their glucometer. For those that are explaining how to use the glucometer, how many of them got a better outcome by understanding how to adjust their doses of insulin based on learning how to use the glucometer? There are several things that we do in the hospital. This is all about checking all those things that we do in the hospital. And how does it improve our outcome, patient outcome? We must be able to check it. We're not just working without documentation. We must be documenting some of the activities that we do, then converting them into bar chart, like I said, or pie chart, to interpret them so that we can compare them with the best practices. But also talk about benchmarking. Compare them with the best. Like, for example, in my hospital, I try to compare. We can also, I take an example, University of Lorraine. When you talk about their drug information center, it's actually one of the best in the country. So if you compare your drug information services with what the University of Lorraine is giving, that should be our benchmarking. So what I'm saying is that whatever we do, we should be able to note it down and see how well we're doing. We can compare ourselves over time, internal benchmarking, or can compare ourselves with an institution. You must compare whatever you're doing with other institutions of similar size. Okay? So what I'm saying is that whatever we do in the hospital, anywhere we are, we must be able to check it and compare it with the best practices available. And like I said, it continues to, the dynamic is a consistent thing. What we are doing today, by tomorrow, it will be obsolete. So we'll continue to improve as far as our patient concerned.
Okay. All right, sir. Thank you.
Thank you very much. I hope that answers your question.
Yes, very well. Thank you, sir.
Thank you very much, Pharmacist Kingsley. Pharmacist Ademola Suleiman, you have the floor, please.
Good evening, sirs, and good evening, ma.
Yeah, good evening.
With you.
Yeah, thank you. I want to thank the presenter. You have actually given us something to look for and something to work on. The aspects in which I actually think you have not been able to emphasize on is the aspect of challenges of implementation. You will agree with me with the little experience of more than 10 years I've had in the hospital practice. Our quality activity is directly proportional to the understanding of the head in the pharmacy and the head in the hospital. So I expected the upcoming pharmacists to also know that these are the likely challenges that that can occur and how such challenges can be overcome. Thank you, sir.
Thank you very much for your question. I can understand it. I keep saying it in the presentation. Quality improvement is systematic. It must be systematic. It's something that is a teamwork. It's something that other healthcare professionals must be carried along to be able to achieve your best. So in doing that, there must be this interprofessional relationship. We as pharmacists must learn how to communicate effectively. We must learn how to relate properly. I can tell you that if you relate properly, it will be easier. The problem we have that, from my experience, right from our school days, pharmacists, we are trained in silos. And when we come out, we also work in silos. Generally speaking, we pharmacists, we have silos mentality because of our training. So it's not anybody's fault. But once you come out of school, you must learn how to communicate, how to interact. You must interact with the doctors. You must interact with other healthcare professionals. Because there are certain things you must do you must carry them along. For example, in my hospital, I'm trying to establish what we call antibiotic stewardship program. And this antibiotic stewardship team, okay, because we found out that antibiotics are being prescribed irrationally, inappropriately. This could be a key performance indicator. We have identified it, that this is the process we want to improve. Okay, so antibiotics are not prescribed rationally. So we decided to improve on it. So we must carry the doctors along. We now form an antibiotic stewardship team. This antibiotic stewardship team, the doctors are involved, nurses are involved, laboratory scientists are involved, nutritionists are involved. So everybody must understand the danger of antibiotic resistance. That's what I was talking about. You must explain, they must understand it, and then everybody must be carried around. You see that it will be easier. So there must be challenges, but these challenges are surmountable. So we as pharmacists must learn advocacy, high-level advocacy. Politics, every politics is local. We must learn how to talk to these doctors and learn how to make them our friends, so that whatever we want to do, it will be easier for us. So that's my advice. Thank you very much.
Thank you very much, sir.
Thank you. I hope that answers his question.
Pharmacist, are you clear?
Yes, sir. But I still beg to say that I understand the angle in which Pharmacist Kislin is actually talking from, being a deputy director. For people like us that had the practical experience, having worked in about 3 different hospitals, and as a young pharmacist that have identified the indicators that needed improvements. You, as a pharmacy grade 1, cannot walk into consulting room to start doing that, especially when your HOD is not in tandem with what you believe in. So I expected that the discussion will also look at the young pharmacists that have all those knowledge, that are also at the forefront, so that you are not going to start thinking like me that, okay, since I cannot get it done very well, let me move to the academics like I am now, and teach them more on how to go in and do better. So what I actually was saying is that the young pharmacists must also be given a template on the way and manners to go about the challenges they're likely to face. Because whether we like it or not, to increase the quality of the clinical pharmacy practice within the hospital, actually need the cooperation of the head of the pharmacy and the head of the hospital. Just like you have said, it has to be systematic. It is because once you leave, it lives with you. But if it is within the system, whether you are there or not, it is within the system, and it is continuous. So thank you, sir.
Thank you very much.
Thank you very much. I understand
Thank you, sir.
I can see we will take this last. I can see pharmacist Folashade Lawal is putting up her hand. You have the floor, ma. You can unmute yourself, ma, and yeah.
Thank you very much. Good evening, distinguished colleagues. You will agree with me, we had a very insightful session, and I'm particularly thrilled at it. I think that we should start devising procedures that we can use to achieve this purpose. Now, an awareness has been created along quality. Can we have a group of people look at this document properly and come up with criteria for assessing the quality in a way that it will be available for all of us to make use of, whether we're in the community or in the hospital? we can start with simple documents that will guide us. You see, because many of these learnings, they're very nice, important. We learn and then we go away, we don't do. But if we have documents that we can use and follow up, then we are likely to have better implementation of what we are learning. So I was just thinking in my mind that is it possible for us in this group to look at a group of people that will look at all these things we've been learning and then come up with, okay, we want to assess the quality of pharmaceutical care we're giving in this place. What are the key factors that we need to have and how do we rate them, and then what will be our conclusions and all of that. Since for now, we don't seem to have a software that captures it. Just my thoughts. Thank you.
Thank you. Well, thank you, Ma. Thank you, Mrs. Olashade, for always being there and for all the inspiration. Thank you very much. Your point is well noted. I think what you have pointed out is very germane. Criteria for assessing quality, it be so that everybody will be on the same page. I think we should look at it on how we can develop a document, like I've said. It's going to be very helpful, like a pamphlet, something everybody can look at, and it'll be easier, okay, for everybody to implement. So everybody will now be doing the same thing all over the place. I know that for us in the hospital, our national body, AHAP, Association of Hospital Pharmacists, has a template of pharmaceutical care in hospitals. We have that already for all the hospitals in Nigeria. We have that document already. Now, for the people I think that document can also go for people in the community. So, Mrs. Folashade, I can get that document across to you, and you look at it and see I can modify it, and then make it work for those in the community pharmacy. Thank you, Ma.
Thank you very much, Pharmacist Kingsley. You've actually done very well. The attendance have kept on increasing, though the time have reached for us to say goodbye. But before that, I will want to invite Pharmacist Folashade Lawal to give us her closing remarks. She's our lead coordinator. We want to invite her for her inspiration and the role she is playing. So I want to invite Pharmacist Lawal, please, to give us the closing remarks.
I don't think she's on the call again.
Okay, I can see Dr. Bello.
Yes, okay, she's back. She's back. She's back. Okay. Let's wait for her now.
Okay.
Maybe he has a network issue, so let's wait for her a while. Okay, she's back now. Okay.
Okay.
So you can repeat your.
Okay. Well, now we are welcome, ma. Pharmacist Folashade, the lead coordinator for this training session. We want to call on you to give us your closing remarks, ma.
Oh, thank you. Sorry, my internet went off, so I just got reconnected. That's why I didn't hear you. Thank you all. It's been a very wonderful evening, and we have a lot of appreciation for pharmacists. Kingsley, he has really taken us through a very important aspect of our pharmacy practice, because no matter what we do, quality should not in any way be compromised or jeopardized. So quality is very key in everything that we do. Thank you. We really appreciate you. And we thank all who have made this happen. To all of you who have participated one way or the other. I'm sure that our practices are getting better by the day, and new things are happening in the pharmacy horizon in Nigeria. So over time, I'm sure that by the grace of God, we'll come up with our own documents that will work for us and will be uniform. I can't wait to see that happen. Thank you all and God bless you.
Thank you very much, Ma. I don't know if Dr. Bello has anything to tell us.
Well, I don't have much. Madam has spoken everything, but I want to commend the speaker and the coordinator for the job well done. We are impressed, we are educated, and we have improved. Like Madam said, we need to really study the document again and come back with something that people can make use of. So I'm taking that as an assignment to get some people who will work on the document and bring out something that could be beneficial to the whole pharmacists in the country by God's grace. And I want to equally say to other members that will be presenting on the next module to please be prepared. I know it's not easy as an adult to do study, but at least we are gaining one or two things. So for the next module, which is module 17, I want to use this opportunity to call on the people who will treat the module to get prepared. At least the next 2 to 3 weeks, you'll come back again and have another good time. Thank you so much for your participation and for your time, everybody.
Thank you.
Well, thank you, sir.
Thank you. Pharmacist Uba, thank you for moderating very well.
Yeah, thank you, sir.
I appreciate it.
Wonderful.
Thank you, Dr. Bello.
Thank you, sir.
So
now it's now time to say bye-bye.
The recording is available live. I will share it for people to revisit and replay. So as soon as we end the meeting, back to you.
Thank you, sir.
Thank you very much.
So it is now time to say bye-bye. We'll have a good night. We'll all pray individually in our privately in our hearts. May God Almighty answer our prayer and grant us our heart desires.
Amen.
Amen.
Thank you very much, sir.
Thank you.
Thank you for the opportunity and have a beautiful night.
Yeah, see you again in the next 2 to 3 weeks by God's grace. Everybody.
All right, thank you. Okay, sir.